My question will be to both the radiation oncologist and Rajnish sir, of course. In lower esophageal cancer in type 1 or say type 2, where we are giving radiotherapy, specifically if it is 50 gray radiotherapy, what is to specifically Rajnish sir, your experience with making a conduit when stomach will be edematous, and is there any difficulty in making a conduit?
I'm not a radiation oncologist, so I can only give you a surgical perspective. In the times when we used to deliver 50 gray and occasionally have salvage patients come back to us after 60 gray as well, conduits do very badly. Why they do badly is a very difficult question to answer. We tried to go back and see the radiation planning fields, and we realized that when the oncologists or radiation oncologists know, or at least have decided that they are not going to get the patient to surgery, they will burn everything. That's the first thing. So stomach used to get a fair dose. The second thing was that when the machines changed from the older, say 15, 20 years back radiation machines to the current machines, which are IGRT, MIRT, the radiation fields improved a lot. So radiation related surgical problems happened in my first 10 years of working in this field. Now, if they happen, I blame the surgeon rather than the radiation oncologist. I'm not sure the answer is clear or not. Today, to say that radiation caused your surgical complication would require you to do very badly in terms of radiation. Today, it's very difficult to do that. Machines have improved, plannings have improved a lot.
Cross regimen rather than neoadjuvant flot. For lower esophageal type 1 cancers maybe, with the risk of this probably will not be able to make a conduit out of the stomach, is it not better to go for a neoadjuvant flot maybe?
Sorry, the question wasn't very clear. The first half I missed it.
Same, that because of the radiation injury to the stomach, to make a conduit in lower G type 1 type of G junction cancer. So is it not safe to go with flot? It will be easier to make a conduit out of stomach.
So pure statistics, I think that's what the data he showed. Adverse events are similar. Cross versus flot, leak rates, everything else is similar. So pure statistics, no difference. And real world scenario, when we realized in the first 10 years of our practice that, okay, we're getting into trouble with the radiation delivery to the stomach, we started sitting with the oncologists during radiation planning and started telling them, I'm talking about my practice only, started telling them where to stop the radiation field. And those things still happen, I guess, in less experienced centers or less experienced oncologists. Cross delivered properly does not cause any increased risk to the stomach. But the caveat is delivered properly.
Sir, what is your regimen regarding prehabilitation before the NSCT-RT and during the NSCT-RT after the neoadjuvant therapy has been delivered? And what are the criteria that you look at to make to assess whether the patient is fit for surgery or not?
No, this is for the surgeon or for the oncologist, because the patient is going to the oncologist. Well, yes, I'll just take the question. So you're right. To be honest with you, oncologist is not very tuned to prehabilitation. That's a fact. So what we have done, at least in our practice, is to sensitize them that, okay, it's not only our business, but your business also to make sure that the patient is prehabilitated, primarily nutritional and, of course, cardiopulmonary rehabilitation. Those things are important. Now, you get about 2 or 3 months when those therapies are going on. And those 2 or 3 months, patient is not with the surgeon. So therefore, it's very important that the physician who's actually treating the patient, which in this case is the oncologist, whether radiation or medical oncologist, is sensitized to the need for prehabilitation in those 3 or 4 months. So that by the time the patient comes back to you, you actually get a patient in a patient you can operate.
Follow-up question on that, sir.
Not only that, I think in high volume centers, one trick is to call the patient on the last dose, last fraction of radiation therapy and not after 5 weeks. Because that's when I think surgeons should talk to the patient, and those 5 weeks before the patient undergoes surgery is a very valuable time for you to prehabilitate, apart from the efforts of the radiation oncologist and the medical oncologist.
Sir, follow-up question on that, sir. Sir, would you consider feeding jejunostomy pre-operatively or before this, or a stenting in case of dysphagia patients?
We do a NG tube insertion. Western patients don't tolerate this, but our patients do well. Feeding jejunostomy, I think, is too much of a procedure. It can disturb, especially if you are a minimal access surgeon, it can disturb your ports, it can disturb your surgery. So we would never prefer feeding jejunostomy unless it is in a palliative setting or or the NG tube doesn't go in at all. So rarely a feeding jejunostomy is necessary, very rare.
That's an excellent point made by sir. This is a myth which is carried out that patient is in absolute dysphagia. How will you pass a Ryle's tube? To be honest with you, you would try under a fluoroscope. 90% of those patients, the Ryle's tubes can be passed. And the advantage you gain is you have obviated a surgical procedure. Now, I know that this is not the way most general surgeons work, but even if the patient is having severe dysphagia, 90% of those patients are a candidate for a Ryle's tube passage. In our own practice, all the FGS done for esophageal cancers, rarely is it ever done for patients who are going to go for surgery, mostly done for in palliative settings where nothing else is possible.
Yeah, I agree with you. Most of the times we'll be able to pass endoscopy. And feeding jejunostomy has a lot of morbidity also. Complications like tube coming out and tube blockage, diarrhea. So we don't advise feeding jejunostomy. So definitely it's possible to pass Ryle's tube and then feed them nicely within a modified formulas are available nowadays, and that's is very good. And otherwise, very rarely we'll go for an endoscopic stenting if there are no other possibilities, like it's only palliative.